guests, Dr. Lam, Mr. Zheng, Professor Holliday, ladies and gentlemen, welcome to the JCJoyAge International Symposium 2021. We will now begin the opening event. I'm your MC, Walker Rao. Launched in 2016, the JCJoyAge was initiated and funded by the Hong Kong Jockey Club Charities Trust, which aims to tackle the problem of geriatric depression, enhance professional and non-professional capacity in mental support, and raise public awareness of geriatric mental health. This is our 5th year running the program, and we're expanding from 12 districts to all 18 districts in Hong Kong in early 2022, hoping to provide standardized prevention and timely intervention services for the elderly at risk of or with depressive symptoms, as well as training over 5,000 ambassadors equipped with mental health knowledge in order to provide mental support for older adults in the community. As an annual highlight event of JCJoyAge, today's symposium brings together world-renowned speakers to share multidisciplinary research findings and their insights based on the framework of healthy aging. The relationship of mental health and the environment will also be explored. This will be an invaluable platform for knowledge exchange among fellow researchers, frontline practitioners who serve the older adult population, and the general public. Let's begin today's program with a welcome message from Mr. Leung Cheung, Executive Director, Charities and Community of the Hong Kong Jockey Club.
Dr. Lam, Professor Holliday, distinguished speakers, ladies and gentlemen, good morning. On behalf of the Hong Kong Jockey Club Charities Trust, a very warm welcome to this online symposium. One of the many lessons of the pandemic is that health requires a combination of physical, mental, and social well-being. Physical health affects mental health, and vice versa. And the environment we inhabit affects both. It is all interlinked. So I would like to thank the University of Hong Kong for setting the stage for today's symposium, also for giving us this opportunity to share insight and knowledge. In particular, the benefits of a multidisciplinary approach to improving the well-being of senior citizens, and all with a view to making this the decade of healthy aging, as called for by the United Nations. The challenge we face is that by 2041, almost 1 in 3 Hong Kong citizens will be age 65 or above. This highlights the pressing need to enhance institutional and community-based services so as to improve the quality of life of citizens as they age. It is also why 2 key focus areas for the Jockey Club's charitable contributions are promoting a healthy community and positive aging and elderly care. More specifically, we want to help citizens adopt an active lifestyle and to increase their longevity through programs which promote their physical, mental, and social health. This lies behind the Trust-initiated Jockey Club Age-Friendly City project, which aims to promote active aging and create an enabling environment for enhancing the quality of life as people age. Likewise, for preventative healthcare, the Jockey Club Community e-Healthcare program uses information technology to help the elderly monitor and manage their own health conditions. And recognizing the crucial importance of elderly mental health, in 2016, the Charities Trust initiated the JCJoyAge program, with over Hong Kong dollar 366 million in funding approved to date. JCJoyAge is a community-based support network which utilizes a cross-sectoral step care model to provide prevention and intervention services to vulnerable and depressed elderly people. In addition, through capacity building programs, it is also seeking to create community capital in support of mental health. Programs have been developed for social welfare professionals, while young olds and retirees have been trained as mental health ambassadors and peer supporters. To date, JCJoyAge has helped around 7,000 depressed or at-risk older adults. Training has also been provided to more than 1,500 ambassadors and 600 peer supporters, who have delivered almost 45,000 outreach sessions. Encouragingly, research data and participant feedback has been extremely positive. Indeed, they suggest that a holistic approach to nurturing mental health resilience amongst senior citizens can be highly effective. Certainly, the work of JCJoyAge has been particularly relevant during the pandemic. In view of this, and with demand for its services growing, JCJoyAge will expand to all 18 districts in Hong Kong by early 2022. None of the initiatives would be possible without the support of our partners and their hard work. Here, I would especially like to pay tribute to the University of Hong Kong and its project team in bringing together many distinguished academics and experts to share the knowledge and vision with us. Also, my heartfelt thanks to all of our 14 NGO partners and our dedicated ambassadors and peer supporters. I should also mention that all of the club's charitable contributions are ultimately made possible by its very unique integrated business model, through which raising and wagering generate tax and charitable support for our community. Last year alone, the club contributed Hong Kong dollar 29.4 billion in tax and approved charity donations. Looking forward to the coming days, I'm sure there will be many insights to guide our future approach to elderly care. Thank you all for participating in this symposium, and I hope you find it productive and useful. Thank you.
Thank you, Mr. Cheung. And now, a message from our guest of honor, Dr. Ching Choi Lam, SBS, JP, member of the Executive Council of Hong Kong, Chairman of the Elderly Commission, and CEO of Haven of Hope Christian Service.
Mr. Cheung, Professor Holliday, distinguished speakers, ladies and gentlemen, good morning. Promoting healthy aging has been a policy focus of the Hong Kong SAR government. We are glad to see that the UN and the WHO have declared the decade between 2020 and 2030 as the decade of healthy aging. Hong Kong has the longest life expectancy in the world. Promoting healthy aging is very much the best solution for us to cope with the population aging challenge. Healthy aging does not mean free from disease. The WHO defines healthy aging as developing and maintaining good functional ability that allows older people to be and to do what they have reasons to value. Older people with chronic illnesses can still maintain a high level of functional ability that allows them to be independent and to do what they value, thus achieving healthy aging. As a medical doctor, I know well that there is no health without mental health. In fact, older people's functional abilities depend not only on their physical health, but also mental health. The Hong Kong SAR government has committed to promoting mental wellness of all Hong Kong residents and established the Mental Health Commission to advise the government on ways forward. The Commission is now studying the issue and will develop recommendations for the government. The Elderly Commission supports the government initiative to provide more integrated and accessible mental health care for older people. In recent years, the Health and Food Bureau initiated the Dementia Community Service Scheme with great success. The project makes new resources available to district elderly centers to provide community support services to older people living with moderate level of dementia and their carers. The scheme is now implemented in all 18 districts of Hong Kong. The citywide medical social collaborative scheme for dementia care offers good example of how we can shift mental health care of older adults with dementia from hospital to community setting. We are eager to see more innovative solutions that promote medical social collaboration and bring mental health services to where older people live. I'm on the advisory committee of the JCJoyAge project. and have been witnessing its rollout and its success in recent years. I applaud the Jockey Club charity's vision to initiate the innovative project that significantly departs from the services as usual. We need more outside-the-box solutions that are in the community and by the community to help address urgent challenges in aging society. I also appreciate the Hong Kong University research team's effort to work closely with the community to implement the project. One signature of the JCJoyAge project is its community-based participatory approach. The research team used a year working closely with the community stakeholders to create and refine the intervention protocols. I was told that the JCJoyAge is the only mental health program in Hong Kong that employs seniors as peer supporters to support older people who have depression. The project also had an ambitious goal of training 5,000 older adults, the mental health first aid, to make them ambassadors to promote mental health knowledge in their own communities. This large-scale, bottom-up, for the community and by the community efforts to promote mental wellness will make Hong Kong more ready for its population aging challenge. Today's symposium comes very timely. Indeed, there is no healthy aging without mental health, and a community collaborative approach is the best potential solution to the geriatric mental health challenge in Hong Kong. I will bring the message back to my organization, which is also a partner of the JCJoyAge project, and to the government. Thank you.
Thank you, Dr. Lam. Finally, a message from Professor Ian Holliday, Vice President and Pro-Vice Chancellor, Teaching and Learning of the University of Hong Kong.
Good morning. I'm delighted to join you virtually for this International Symposium on Healthy Aging. The aging population is a global challenge, yet most older people reside in mainland China, Hong Kong, and nearby countries in Asia, the least resourced and prepared area in the world for aging. Southpost Centre on Aging has developed new assessments and protocols for long-term care resource allocation in Hong Kong, and has also conducted feasibility and acceptability studies on using service vouchers for long-term care in Macau. Our future studies have shown that older people need to have a choice of long-term care arrangements, whether to age in place or to receive care, within Hong Kong and the Greater Bay Area. In the Department of Social Work and Social Administration, our MSOC-Sci program in gerontology has trained generations of leaders within the field. Our international focus is summed up in our motto, no healthy aging without healthy mental health. In SWSA, we've piloted a dementia community support scheme evaluation for the Food and Health Bureau of the Hong Kong SAR government, and the suggestions were adopted by the government to enhance the scheme. It also has a multinational collaboration project on developing dementia care capacities, which is funded by the Research Grants Council. The JCJoyAge project is a partnership with the Hong Kong Jockey Club to initiate a citywide project which since 2016 has made mental health care for older people with depression more accessible through a new stepped care service model, enhancing older people's mental health literacy through a community-based participatory research process. Our findings are that the stepped care model is between 4 and 6 times more effective than traditional services. Looking ahead, the project will be expanded to all 18 districts of Hong Kong in the next 2 years, 2022 and 2023. Today, the achievements of the JCJoyAge project in the last few years will be shared with all participants. Dialogues will take place with local and international stakeholders on older people's mental wellness. Joint collaborative efforts undertaken by all stakeholders are essential, including the government, charities, university researchers, and grassroots communities. Hong Kong and Hong Kong U are committed to promoting a healthy aging. As I said before, There's no healthy aging without healthy mental health. Healthy aging enables older people to be and to do what they value. We're honoured that the JC Charities Trust invited us to be the partner to develop and implement this great initiative. We're grateful for every individual in the community who talked with us and walked with us throughout this journey. Thank you very much and have a great symposium.
Thank you, Professor Holliday. This is the end of the opening event. Thank you for joining. We will now take a break until 10:30 a.m. Hong Kong time. After that, we will proceed to a panel discussion hosted by Professor Mike Martin of University of Zurich and Professor Terry Lam of the University of Hong Kong. The topic of the panel discussion will be the WHO Healthy Aging Framework. It will include 2 presentations by the 2 speakers, followed by a panel discussion and a Q&A session. Please stay tuned for the session. Dear guests, welcome back to the JCJoyAge International Symposium 2021. Before we start, we would like to remind all that the event will be recorded. It will be available online later, so you are more than welcome to share this with your colleagues and fellow researchers. There will be a Q&A session at the end of today's presentation. Please feel free to send us your ideas and questions to our speakers by typing at the checked box anytime during the presentation. We will collect these and address them during the Q&A session. We will now begin our session. The topic is World Health Organization Healthy Aging Framework. We are honored to have Professor Mike Martin from University of Zurich, who has been working on gerontopsychology and has helped shape the WHO Aging Framework. We also have Professor Terry Lam here on the live stage. Professor Lam has done extensive work in both local and international gerontology. Both Professor Martin and Professor Lam are members of the WHO Consortium on Metrics and Evidence for Healthy Aging. Each of them will give a presentation on healthy aging. Then there will be a panel discussion to compare how the WHO Healthy Aging Framework applies in the Western and Eastern world, and the Q&A session to interact with our audience. Let's now pass the time to the speaker. Professor Martin is joining us live today in Zurich, very early in the morning as well. I will now pass the mic to Professor Martin, please.
Thank you very much. It's an honor to be here and try to provide a little bit of feedback on the Decade of Healthy Aging by the United Nations and the World Health Organization. What I will be trying to do is give you a short history, how it came about from the World Report on Aging and Health in 2015 to what we now call the Decade of Healthy Aging, or in brief, just the decade. I want to get into, because I think that's the most important aspect of this, the healthy aging concept is really redefining health as we know it, but it's not just a conceptual change. The main issue is that it changes the public health approach. What is it that public health goals should achieve? This is very new, and I will get into this because I think that's the most important aspect of that new concept. I'll also try to give a brief overview of where do we stand globally in this year at the start of the decade, and what are some of the innovation challenges for the decade. And there are quite a few, so I'll just pick very few of those. So the history or the background is when the decade redefines healthy aging and health in general, then why is this timely, or why is this even needed? There's a number of developments that made that necessary. So if you look at Hong Kong, which is quite comparable to Switzerland, where I am right now, you see there's this one development, and that's the increase in life expectancy on a global scale. It's almost 10 more years of life expectancy in Hong Kong over the last 40 years translating to about 90 days that everyone is gaining per year since about 40 years on average. So individuals and populations live much longer, significantly longer compared to 30, 40 years ago. The second development that we see is that as people get older, they also increasingly are in better shape. So if you look at the world records in the 100-meter dash outdoor, the current level, you can see what the world records look like for the 60-plus-year-olds, and I assume that at least I cannot beat them, or even the 85-plus-year-olds for men and women. And the interesting thing is how these times also have evolved over the last years. So the world record in the 100 years and older category has been broken several times in the last few years, which indicates that people, as they get older, some of them at least, and the top performers, also get much fitter in that old age. So that's a second development. So people live longer, and they can also be much more functional or better able when they reach that old age. Now, there's a third development is multimorbidity. If you look at chronic diseases, the amount of chronic diseases and the distribution in the population, a very large proportion of people being 85 and older is suffering from multiple chronic diseases. And these multiple chronic diseases is one aspect to consider. That is, instead of having a particular illness, it is much more frequent and the most frequent disease in old age that people have multiple chronic illnesses. And this is the main reason why there was a need to redefine healthy aging. Based on the multimorbidity diagnosis, most individuals aged 85 or older would have to be considered ill or not healthy. On the other hand, these same individuals with 5 or 6 or 7 chronic diseases can be your world record holder in the 100 meters. So what are they then? Are they healthy because they're highly able in terms of, for example, their running performance, or are they ill because they suffer from multiple diseases? They're both. And this is why there was a need to redefine what healthy aging means, and I will get into this in a minute. So in 2015, actually, I was surprised to learn this. There hadn't been a world report on aging and health ever before. So it's the first time that the World Health Organization was trying to get information on where we stand in terms of aging and health on a global scale. And there were quite, to me at least, a number of surprising findings. One was in many studies about aging and health in aging, individuals older than 70 were excluded. And one of the reasons is that researchers fear, for example, that their research participants might die in the course of their study, so they exclude them to begin with. The second thing is that most of the research in health and aging is focused on particular diseases, for example, dementia. And this is instead, however, what would be needed is to include individuals with multiple chronic diseases or multimorbidity, but those are mostly excluded or have been excluded from research on aging. It's really strange because on one hand, it's the most frequent phenomenon. On the other hand, this is the reason why it's excluded. So we have clearly biased data when it comes to aging and health, and we have data gaps. Also, when data are collected and if health was assessed, it was often done on the level of individuals having or not having diseases, and on an overall population scale. But health often is a phenomenon that occurs as a phenomenon within a community. So communities, for example, where individuals care for each other are quite different from those who leave everyone alone and where there isn't a community-oriented healthcare system. A fourth aspect that is often excluded is real-life context. Interestingly enough, although the Open Life Data Framework suggests that 85% of all health-relevant data occur and are generated in real life and outside of clinical context and studies, studies still represent the largest proportion of the data that we have about aging. And quite often, what you find in a clinical environment and with clinical assessments has relatively little to do or little transfer to real-life context. And this is an uncharted territory, interestingly, at least for research. And finally, it is also often excluded what matters to older persons and the communities, as most of the data that are existing or have been existing are about diseases and not what's important, what are the goals of individuals or what are the goals of communities. So this was the reason that 1 year later, after 2015, WHO, the World Health Assembly, agreed on a global strategy and plan of action. And among the five objectives were a commitment to action on healthy aging in every country. The argument WHO is making is that although it's a global challenge, it has to be addressed locally, regionally, or nationally, because the contexts obviously are quite different and the conditions or what contexts are available are quite different. The second is developing age-friendly environments. This is based on the belief that most of the things that influence well-being and health in aging is policy dependent and can be shaped. So the environments or contexts are key to improving and maintaining good health. Third is aligning health systems to the needs of older populations. And this is quite a difference in what we see so far, where health systems are aligned to the symptoms of older populations. And that is making a big difference because you need to know what the needs of the older populations are and then align the systems around those needs. And I will try to demonstrate how this is quite a different approach to what we see right now. Developing sustainable and equitable systems for providing long-term care. And then finally, improving measurement and monitoring on healthy aging. And this has to do with the definition of what healthy aging is, because otherwise one could assume we may already have all the instruments that are needed. But one gap that we have is from about over 200 countries in the world, only about 100 have some data on healthy aging, and only about 25 of the countries worldwide have holistic data on functional abilities, intrinsic capacities, and also the needs of older populations. So that clearly is a minority. And the idea was then to spend 2016 to 2020 to prepare for the current decade of healthy aging. And I'll show you a few of those investments. So if healthy aging now is the basis of public health, then what's so new about it? Well, one thing that's new about it is that at the core of the definition is functional ability. And functional ability is often misunderstood as a term for functional impairment or functional health. These terms are familiar to people that, however, are in fact impairment measures. But functional ability, and that's why I'm trying to point this out, is being and doing what a person has reason to value. Or like Olive Bryanton puts it, we must listen to the voices of older people on what matters most of them in their daily lives. That's, in her words, what functional ability is. And this is also the main challenge, because what this means is that to do what a person has reason to value is different in each of us, in every single person is different. It means you have to measure functional ability as something that's specific to persons in their context, and you have to be able to measure it in the whole population and worldwide. And this hasn't been possible until the upcoming of sensor-based assessment tools, because otherwise there's simply no possibility to do this in such a large scale. So this is also a definition of health that takes into account the relatively recent technical developments. The second thing that is new about this is that it basically suggests that functional ability is made possible by an interaction, a systematic interaction between all the abilities, activities, traits, skills, and disease. So all the individual characteristics work together to make this possible. So the question, what you have to eat in order to be healthy, is not a question that such a model suggests, because this model would always suggest eating and other behaviors and abilities all the time interact with each other within each person. So you cannot look at it from the perspective of any single aspect of this. The third part that's new is that environments are emphasized as being part of health. We used to think about environments as a predictor of health. So better environments cause better health. Now here it's actually the environments themselves are part of health. In other words, given two people who have exactly the same individual characteristics and where the functional ability would also be defined in the same way, are by definition different in their health if one person has more opportunities to use that or perform that functional ability versus a person having fewer opportunities. A fourth element that's new are these, light blue arrows. They represent the interaction between environments and individuals. And this in health research is often overlooked. It is where people make decisions, for example. Do they perceive the opportunities that are there in the environment? Do they decide to act on those environments? So it's people being aware and being decision makers in health. And the decision making itself and having choices, again, is part of the definition of health. And so it could also be the target, for example, of interventions. So providing, for example, educational opportunities for older individuals and making them accessible remotely, for example, is an important intervention in order to improve or maintain health. And then finally, what this here doesn't really visualize is it's a dynamic model. Because obviously, if abilities change, activities can be adapted, environments can be adapted, and also the way we evaluate the environment and the opportunities in the environment can change. So it's a dynamic model. And what you cannot see here, it's not only about that healthy aging can be improved, but an important goal of healthy aging is its maintenance. So stabilizing healthy aging. So an intervention isn't necessarily good because it improves functional ability. It is necessary often to maintain functional ability. So given changes in the person or the environment, how can functional ability be maintained? So it's the first time the World Health Organization has used the dynamic systems approach to define healthy aging. So it is in many ways different. And as I said, it's not just a conceptual change. This is the concept that is now supposedly, at least by the end of the decade of healthy aging, the main goal, how our public health systems worldwide should be organized to improve and maintain functional ability of all older people in the population. And here comes to one of the challenges. As WHO representative Ritu Sadana at one point said, you can only change what you can measure. And to improve functional ability in the population, functional ability must be measurable in every person in the population. So how can you do this? So one approach that's currently being taken is agreeing on what probably represents essential parts of the functional ability of people all over the world. So one element is meeting everyday basic needs. And the current status is that about 142 million people in the world, being 65 or older, do not have their everyday basic needs being met. So that's a really important information. And there obviously is things to do. And these 142 million, unfortunately, are just an estimate. We do not have exact data at this point. And this is why there's this call to action also by WHO to improve the database to make public health planning more feasible. Building and maintaining relationships, so communities and the care within communities is making a big difference. Staying mobile, continuing to learn and make decisions, and contributing to family and communities. There's this global consensus, are key ingredients of functional ability. And this is where, on a global scale, different countries try to find indicators where they have data and data collections that have been ongoing so that they can extract those. It's only an approximation, though, on what functional ability is. As I said, functional ability is being and doing what persons have reason to value. So how do you know, or how can you assess what people are doing, and if what they do is what they have reason to value? That isn't always necessarily the case. And there's multiple ways of doing this by now. This is just one of the devices that we have been using, and colleagues at Hong Kong University with Terry Lam, and colleagues in Mexico, Professor Gutierrez, and in Australia, Professor Pajana have been working on. This one that we've been using in our joint research is measuring and tracking positions, where people are, how they move around, what kind of physical activities they perform while they do this. This allows to distinguish between quite detailed different types of activities. And we use also sound recordings to extract social activity information. So we have physical activity, mobility activity, social activity. Increasingly, we hope that there's also other activities that can be better tracked. These could include emotional activities, but it could also include heart, brain, or other activities within the person. So it isn't necessarily within or outside the person. And indirectly, at least, this also allows to track context information. And that could be any aspect of the context. Now, with those data available, what we've just been talking about is what some have called the exposome. What are people exposed to? So the context information and their own activities. But we also have increasingly rich data also on the level of each person, genomic, proteomics, metabolomics. So these are all developments in science that add to the amount of data that are available. And these data have interesting characteristics. The richness of such data in principle allows something that hasn't been possible to do until relatively recently. Most of the public health information and studies that we know use population estimates. That is, what is true for a group of people, what is the risk for an illness, for example, in the group of 65-plus-year-olds. This is a typical public health data. Here you can now use the richness of this information from different sources to make individual predictions or individual interpretation models. So you can specifically determine for a given individual what the risk is. This is quite different from what we currently know. Currently, when we have a population 65 plus, where let's say 13% of the population suffers from dementia, then no single person within the population has a 13% risk. Every single person in that population either has a 0% or 100% risk. And this is what is making public health targets or interventions so inefficient, because they're built around a 13% risk that is assumed to be a 13% risk in every single individual, when in fact in every single individual the risk is 100% or 0%. What we would need to find is what is the actual risk of a given person. And this is what these rich individual data allow on a large scale. So that's the main difference. So how do we get to even better information? These are what we call retro-harvested data. We basically have used different devices and imputation models to extract mobility information on a second-by-second basis from late 1982 until now. It's in one person, 1 billion data points. The more light the colors, the more active the person, and the darker, the less active. So basically, the black areas is non-active periods, and this is sleeping times, basically. And then you can also see more activities here between mid-July and mid-August. And you can see, for example, more activities over 6 months here and less activities over 6 months following. So what you can know or learn from these data is this must be a professor and from Switzerland, because he's very active in the summer. That's when there's no lectures. And here he had a sabbatical of 1.5 years, 6 months, where he was very physically active anytime he liked. And then after his sabbatical, returning to the university, he had to pay for it with committee work and a lot of sitting indoors. So in these rich data, there's lots of information in there if you can only extract it. And this is just data from one person, so you need to extract it from every person in the population. Also, what you can see here, it's data from that same person from just 1 month, March 2020. In Switzerland, the government decided on a lockdown, a COVID-related lockdown, on March 15th. And the black lines that you see throughout the month of March is physical activity. And if you only look at the amount of physical activity, there was no difference between the first and the second half of March. That would suggest that that person didn't adhere to the lockdown recommendations of the government. However, if you add weather information, here in yellow, it's when there is sunshine, good days. In Switzerland, the first half of March 2020 was mostly rainy, and the second half of March was mostly sunny. So in relation to the opportunities to be physically active and be outdoors, this person actually massively reduced its physical outdoor activity. So only the context allows you to interpret the physical activity information. And this is what we call small data. Although these are huge amounts of data, they're small in the, so that could be big data. They're small in the sense that it's clear that these data stem from just one single person and who that person is. So these data cannot be anonymized because they're simply too rich to be anonymized. On the other hand, using that context information and put it all together analytically is then the only possibility to measure functional ability in real time. And this is what we aim for, working together with Hong Kong University and colleagues worldwide to establish a standard of measuring functional ability, including context information. So in terms of the decade of healthy aging, the question is, where do we stand right now on a global scale? So one development you're familiar with is the number and the percentage of people being 60 years and older will clearly increase. What WHO is about to do is, instead of focusing on disease only, so here you see an arthritic hand of an older person, this has been the standard before the decade, is to see health more like this, where that illness is one aspect that you're interested in, to the degree it can also be treated, but also to look at the function. So a person with an illness who, however, also is able to maintain their functional ability, taking care of others that are important to them, is important information to have. And in addition, what the developments are and what we're interested in is really looking at the determinants of healthy aging and to the degree they can be shaped. And most of the determinants of healthy aging can be shaped. So one of the measures that has been taken in the baseline report for the decade of healthy aging is looking into different of the global regions. So here's the European region and the Southeast Asian region. And you can see the percentage of countries reporting a national plan on aging and health. Clearly, the Southeast Asian region is much more advanced in 2020 Most countries by now have such a plan on aging and health, but Europe is pretty much behind. So, for example, Switzerland does not have a national plan on aging and health at this time. They have, interestingly, a national dementia strategy, but not one on aging and health. As every country has committed itself to have a national initiative to put the global initiative in or establish it in its region, then what you would expect is that countries also establish multi-stakeholder forums. And here again, you see that Europe is a little better than the Southeast Asian region, but there's plenty of way to improve. This is really not well advanced, comparatively speaking. National programs to foster age-friendly environments. You can see that here there's also a lot of improvement needed, although you can see through the precursing years of the decade of healthy aging that already has improved quite substantially. The age-friendly environment, something that this symposium is also dedicated to, is really making a big difference, because this is where the environment and the community context is changing. Countries with a national policy to support comprehensive assessments of older people. This is the area where there's a clear lack of data. We see some improvement, but if you look into the type of data that are being collected, they're not sufficient, because most data collections have been designed with an older health model in mind, and that is health is either the absence of a disease or more than the absence of a disease. So basically, it's measuring disease. So everything besides the disease, that's the lack and that's the gap that we're missing. So there's clearly room for improvement. Now, if you look at the availability of longitudinal data on the health status and needs of people, again, there's a huge gap in data being available. And as indicated earlier, if you don't have data, you can't track improvements. And there's also no incentive to improve, because there's just no way to document how far your dollar went, basically, when it comes to improving the health in the population. You also find, at least before the decade, that the gap between life expectancy, like I showed for Hong Kong, an increase of about 10 years over the last 40 years. But the gap between life expectancy and healthy life expectancy has increased in many places. That is, from the added years that people live longer, a relatively larger proportion of years are unhealthy years. And this is an important indicator that we need to address that functional ability better when it comes to healthy aging. So supporting functional ability, something that the programs that are designed and put in place in Hong Kong currently should make a big difference. And these data then will allow to track that. So currently, and as I said, in over 200 countries worldwide, less than 100 have data on aging at all, and less than 25 countries in the world have data on functional ability at all. So these are huge gaps. And currently, the Cochrane Group is working with WHO to track the evidence gap map in order to see and track over the next 10 years if those gaps, change, hopefully get smaller, and then we have better data. Now, the data are important not only to have data. The more differentiated data you have about aging, the better and more tailored the interventions are going to be, and innovations built on in what individuals differ as they're aging are much more important than what they have in common. There's currently, most of the innovations in the aging field are addressing people in nursing homes or with dementia, although that's a minority of older people in that situation. And it's because of the way these data are being collected and reported. Had we more differentiated data, we would also see a difference in the types of innovations. And this is why WHO is now stressing what the innovation challenges for the decade are. And they see it as a pathway to optimize functional ability. So as you can see, one is clarifying what will be optimized within each domain and setting priorities. This has to be done on a community by community or a country by country level. Identifying interventions and respecting the context in which it takes place. So what works in Hong Kong may or may not work in Switzerland. So you have to do it with respect and including context information, but also see what works, similar to what you've been doing in Hong Kong. Assess the intervention impact with older people. So they're part of the research. That's important, not only because it's a nice idea. It can only be done because they define what's important for them in terms of their functional ability. Evaluate what works, address scalability. That is, don't just try out an intervention, show it works, and then leave it. No, you really have to think early on. If it works, how can you scale it up so it reaches individuals? And then accelerating impact. This is where WHO is also calling to work with public and private sectors to make sure that when something is developed and an intervention works, it can be scaled up, and there's partnerships with the private sector. So this is addressing the aspect of better data combined with an accelerator like this process will also reach then people's doorsteps and improvement of health. Now, in terms of the challenges for innovation and how to approach it, here's one thing that needs to be mentioned, and that's the between-person trap. So most data that we currently have on health and aging are cross-sectional data, if at all. And these cross-sectional data are problematic. Here's a hypothetical example. If you do a cross-sectional study, compare people of different ages, for example, but here simply you have a sample of individuals and let them write the text on a computer keyboard. And what you find is that people who write faster, more words per minute, are the ones also producing fewer typos, fewer errors. So you have a negative correlation. The faster people type, the fewer errors they make. So if you use such data to make a prediction for a given person, what should you do as an individual to reduce your error rate? You would say, well, if you want to reduce your error rate, then simply type faster. But within each individual, exactly the opposite is true. No matter how fast you're typing, if you start increasing your speed, you will increase the number of errors. And this is why these cross-sectional data lead sometimes to completely wrong recommendations on an individual scale. If you want to make recommendations for a given individual, those cross-sectional data cannot be used. They're simply wrong, the wrong design. They're useful for describing populations and incidences in populations, but they cannot be used by design to make individual predictions. These need more richer within-person data and short-term within-person data, like what I showed you from that Swiss colleague, the physical activity data over many years. And the second is a complexity trap. The type of research that we've been doing so far and where we thought we can create innovations is that we looked at aging and health disease by disease. So let's assume that every single disease, costs you 5 days in hospital to treat. Then the assumption is that as people have more, then you add on the burden basically in a linear way. So the expected cost is basically additive. That's the model behind most of the health research that we've been doing. And this is then missing innovation opportunities, because we know that in fact, the observed costs when you have multiple morbidities are exponential. And the reason are the increasing numbers of interactions between those diseases and the needs of individuals. And most innovation has been targeted based on such an additive model, when this year the complexity gap is where most innovation is useful. This is, for example, where you think about how you can tailor an intervention better by contextualizing or orienting it more closely to the community you're in. Contextualized and individualized also requires different data models where you can keep the data on the level of an individual, let's say on a smartphone, for example, and these data can stay within the individual. And so you can run your trials much faster, and you can even use natural real-world experiments using smartphone data as they're being collected for health studies. And this is another area of innovation that is currently developing quickly. Now, contextualizing these data is one thing, having such data, but the other is interpreting them rapidly. This is a completely new field, semantic activity analytics, and I'm the leading author in this field, but the only reason is I'm the only author in this field at this point. But I think this is really just an emerging new field where people are trying to find ways of interpreting health data, these rich data from different sources. Why is this useful? Let me just give a brief example. If you had such real-life data, these, for example, are data 5 days, second by second, on physical activity states of 2 individuals being 80 years old. This is an 80-year-old over 5 days with severe chronic pain, and this is a same aged person without severe chronic pain. And the difference between the two does not lie in the types of physical activity or in intensity or duration. They're the same. But this is a more predictable pattern, and this is a less predictable pattern. So the degree of complexity in movement patterns is meaningful. It means that this is a healthy person and this is a person with severe chronic pain. And this information can be extracted if you find clever ways to interpret such data. Now, if you can use such data, then you also have a new possibility. So although on average, we know that individuals with cognitive impairment or dementia are more likely to be disoriented, when we now are tracking individuals over time in their real-world context, then we see in very few cases are these individuals really disoriented. So this person, for example, although being cognitively impaired, is not disoriented ever when we observe them. So something that's based on the average difference in the population would suggest that everyone with dementia should get navigation support every minute of the day. But these data suggest that you would be wrong in up to 100% of the situations. And clearly this is inefficient. And a navigation system that unnecessarily tells you where to go, you will turn off, so it will not work and even has counterproductive effects. So this is an opportunity to tailor interventions more to the situation in which, for example, in this case, disorientation occurs, instead of the trait, the stable trait of a person, for example, having a diagnosis. And this is exactly what we've been working on in terms of the clinical trials, because that's then the new consequence is running real world clinical trials, and they can be as randomized as strict clinical trials, and where we've agreed on a global scale to basically align our designs in having baseline assessments and then adding daily assessments or minute by minute or even second by second or millisecond by millisecond basis, and then post-test designs. We've started with about 7 to 30 days of assessments that included Switzerland and Hong Kong. We're now up to 300 days already, and maybe eventually longer. And these designs have included people up to age 93, from 0 years of formal education to many more years of formal education. So this is now the standard that we hope to establish by 2023 as a standard clinical trial taking place in the real world. So why is it worth it, or is it worth it to invest in the decade of healthy aging? Just consider that what you find in the baseline report. We can have 3 scenarios. Basically, if we don't do anything, what's happening, or if we really achieve our goals. And these goals include that governments, civil society, and private sector work together to optimize functional ability. There's a lot in it for everyone. And a better distribution of global investments in progress. Then we can expect that attitudes towards older adults change in a positive way. And we see accelerated improvement in the engagement of older adults. And this, I think, can be looked at in different ways, from a financial value perspective, as well as from a social value perspective. Clearly, this is the reason why so many countries in the world have agreed to support the decade of healthy aging. And I'm very happy to see the developments in Hong Kong, and I'm looking forward to the symposium and its contributions to see where you stand at this point. Thank you very much.
Thank you, Professor Martin, for your inspiring sharing. We get to know how the concept of healthy aging has evolved over the years and how the new research will be like in the coming decades. Now, it will be Professor Terry Lum's turn to talk about how the Eastern world has assimilated the concept of healthy aging and adopted a task-shifting model in services for older adults' mental health. Professor Lum, please.
Thank you, Walker. And thank you, Mike, for the very inspiring presentation. I particularly enjoy the time you talked about the data and also talk about the scenario. If we don't do anything, actually, I don't know how we can cope with the rapidly, population aging phenomenon in the world. In fact, I don't believe we can prepare the world for population aging by building more hospital or clinic. If you look at the population aging, there are two sides, right? One side is there will be rapidly increasing demand in various services. But on the other hand, there will be a decline in the supply of manpower who can serve, the rapidly increasing elderly population. So the only way we can really prepare for population aging is by promoting healthy aging. And today, I will shift the focus a little bit in my presentation, moving from healthy aging to mental health. So I am kind of making the statement that there is no healthy aging without mental health. In fact, mental health is a very core component of functional ability that enable older people to be or to do what they have reason to value. But before I do anything, let me talk a little bit about the JCJoyAge project. So the project was initiated by the Hong Kong Jockey Club Charity Trust in 2016 and was implemented by the University of Hong Kong research team. And I am the project director of this project. The overall objective of the JCJoyAge project is to develop a viable and sustainable best practice model to promote elderly mental wellness and prevent elderly depression for Hong Kong through a community empowerment strategies. So the community actually is at the very core of our approach. We are in the fourth years or the fifth years of the whole implementation. The project started in October of 2016. And for the first 3 years, it was a pilot project. So it was implemented in 4 districts in Hong Kong. And we did a quasi-experimental design and collect information on the effectiveness of the model. And then the outcome was really good. So in 2000, the Hong Kong Jockey Club Charity, we invest more resources into this project and moving it from a pilot to a citywide implementation. So as of today, the project is being implemented in 12 districts in Hong Kong. And by next year, 2022, the project will be implemented in all the 18 districts in Hong Kong. Let me talk a little bit about the mental health challenge in aging society. So globally, about 15% of all older adults are suffering from mental disorder. And the most common mental disorder in this age group, including dementia, about 5% of the world older people are living with dementia. The second one is depression. And 7% of the world older person are suffering from depression. And then about 3.8% of older people are suffering from anxiety. 1% are suffering from substance abuse. And then if you look at people who, committed suicide, a quarter of deaths from self-harm are among people who are 60 and older. In Hong Kong, each year we have about 250 to 300 older people who committed suicide. In the WHO report, it also said the mental health of older people can be improved through promoting active and healthy aging. So healthy aging, in fact, is a solution also, for better mental health well-being. Mental health is not new, in the WHO agenda. The WHO has a 2013 and 2020 mental health action plan. In that action plan, the WHO highlights 4 major objectives. The first one is to strengthen effective leadership and governance for mental health. The second one is to provide comprehensive, integrated, and responsive mental health and social care services in community-based setting. The third one is implement strategies for promotion and prevention in mental health. And the last one is to strengthen information system, evidence, and research for mental health. In the JCJoyAge, actually, we focus on two areas. The first one is to provide comprehensive, integrated, and responsive mental health and social care services in community settings. Our response to this one is that, JoyAge task shifting step care model. And then we also look into the promotion and prevention. So the WHO call for implement strategies for promotion and prevention in mental health. Our recommendation or our strategy is to develop and implement the JCJoyAge ambassador program and the JoyAge community-based participatory approach to promote mental wellness. We also put our resources to strengthen effective leadership by providing professional training for mental health professionals as well as social workers in the field. We did comprehensive evaluation on the outcome effectiveness of the JCJoyAge clinical intervention as well as the cost effectiveness of the intervention. And let me first talk a little bit about task shifting. So that mental health treatment is often provided by licensed mental health professionals in specialty settings. And this specialty provider may not be available due to workforce shortage, cost of care, or accessibility issues, especially for the low and middle income country. And then the WHO recommend a task shifting mechanism, to counter this kind of manpower shortage. And WHO define task shifting as specific tasks are moved where appropriate from highly qualified health worker to health worker with shorter training and fewer qualifications in order to make more efficient use of available human resources for health. So the task shifting is shifting some of the tasks when appropriate from very specialized trained professionals such as psychiatry, clinical psychologists, to professional or health worker that require shorter training. So if we put this into perspective, we look at the Hong Kong situation. In Hong Kong, we have 426 psychiatry total in the city. It is about 5.7 psychiatry per 100,000 residents in Hong Kong. And then if you look at the clinical psychologists, we have 607 clinical psychologists in Hong Kong. And then there is, however, if you look at where they are working, a majority of the clinical psychologists are working in private sector. So only 105 clinical psychologists are working in the public sector. And amongst the 426 psychiatry, 390 of them are working in the public sector. And a small number, a little bit more than 100, is working in the private sector. So if you look at the number of public sector psychiatry per 100,000 older people in Hong Kong, it is only 3.2 psychiatry per 100,000 people in Hong Kong, versus, for example, the other high-income country, it is about 8.6 psychiatry per 100,000 people. So in that sense, although economically, Hong Kong is a developed economy. However, if you look at the healthcare resources, we are still more like a middle income to low income place. Hong Kong also have 26,800 social workers. These are the people who receive professional social work training. However, very small percentage of them are working in the mental health sector. So if we are talking about task shifting, a logical step is to think about training more social workers to become mental health services provider. However, the current training in social work academy is not specific enough to prepare them for this challenge. So, in the JCJoyAge project, we are using the task shifting approach to handle the manpower shortage of professional mental health services provider, as well as the accessibility issue. So in Hong Kong, if you look at specialties, outpatient psychiatric clinics, we have 19 of them. And then most of them are associated with hospitals. And then these are the, public specialties, outpatient psychiatric services run by the hospital authority. And then we also have 24 integrated community centers for mental wellness. These are mental health support centers run by the social welfare department. So in the ICCMW, the Integrated Community Center for Mental Wellness, they have a multidisciplinary team, including clinical psychologists, OT, occupational therapy, physiotherapists, as well as social worker. In fact, social worker are a major, professional staff in this center. We also have 41 district elderly community center. So we have 18 districts in Hong Kong and 41 centers. That means each district will at least have 2 or 3. Some districts even have 4, district elderly community center. These centers are more for active aging. So they organize healthy aging activities or, active aging activities for older people. And they are membership-based. That means in order to participate in this activity, older people first join to become a member. In recent years, the government also asking those centers to provide more health-related activities or health promotion activities. For example, Dr. Lam, one of our officiating guests, also mentioned in recent years, the government asked the district elderly center to provide dementia support services for older persons living with dementia, moderate level, and also they have a stable condition. So in the JCJoyAge model, what we did was we train up a group of social workers in the elderly center. We provide them specialty trainings on elderly depression. And then we add additional resources to this center so that they can establish a team of, mental health professionals led by social workers to provide mental health services for people who have low, mild to moderate level of depressions. We also add resources to the Integrated Community Center for Mental Wellness. So we also provide specialty training for social workers in the ICCMW. And then we put them together as a team to take care of mental health care needs or older people who are facing challenge of depression. So we have a step care model. So if the older person in the community has, for example, mild level of depression, however, their treatment will be in the district elderly center. However, if after some time when they complete the first course of treatment, there is no improvement, then the case will step up to the ICCMW to receive more specialized training. If older people who receive mental health services for depression in the hospital's outpatient clinic, but their condition has become very stable, and the hospital outpatient clinic may only offer a meeting or intervention with them once a year or twice a year. However, in between, they are not receiving, regular services. Then the hospital can refer the case to the JoyAge team in the integrated community center for mental wellness. And the social worker over there will do an intake and will assess their whether they are a suitable patient for the clinic. If so, then we will intake the case and we will provide regular services to them. So the first level of task shifting is moving the mental health services for older people with depression from a more specialties outpatient setting to, community setting in either ICCMW or the district elderly center. So we provide a very comprehensive training for social worker. So the training include more than 200 hours of both lecture and practicum. So far, since that we begin the project, more than 70 social worker has received this intensive training. So if you remember, we have only a little bit more than 100 clinical psychologists working in the public sector for people with mental health challenges, and they serve people of all age. That means that 1,100, clinical psychologists, they serve children, non-elderly adult as well as adult, and we have 300 something psychiatry. But then we add more than 70 social worker in the system, and they are working in the NGO setting, so they are in the public sector. So we have significantly increased the manpower of mental health professionals in the public sectors. So the training has 4 components. So the first component is on the concept about late life depression, and then talk about clinical knowledge and assessment skills, particularly the evidence-based practice. So we use the CBT as the major intervention modality. And then we also teach them about peer supporter and the concept and the practice, and then the step care model. And then after the training, they also do a practicum and under supervision at their workplace. And then we also provide ongoing supervision for them. And the second task shifting is from professionals to peer supporters. So we also follow the recovery model, and we target older people who have experience with depression. So in the last few years, a total of 412 peer supporters were trained. They received 80 hours of training in theory and practicums that involve 2 levels. The basic level is the phase 1 curriculum, plus the storytelling, how to use their own recovery story, their own experience with depression to help other older people with depression. And then the advanced training will also include some facilitation skills for individual planning, goal attainment, as well as we also train them the wellness recovery action plan. So this is the training we provide to the peer supporter. And after they receive the training and they complete the practicum, they are hired as part-time project staff. They work under supervision of social worker, partner with the social worker. They use their own recovery experience to facilitate the intervention process. So I just want to give you a little bit about the profile of the peer supporter. So these are data from 152 peer supporter who participated in the training in phase 2, that means in the last 2 years. So the average age is 62, and most of them are female as expected. And then 92% of them has secondary school education or above. And then 78% of them are retired or homemaker. So in other words, we still have about 22% who are working. 61% are married. And then 90% are living with other people. We also measure that, some of the, outcome to see whether, the empowerment really working. And to a certain extent, they are higher on empowerment and resilience as measured by the standard scale. Another task shifting is ambassadors. So unlike peer supporter receive extensive training. So a total of 100 hours, including both training as well as practicum. And then they are hired as project staff. Ambassadors are older person themselves. And then they receive training on mental health first aid. And then they also be trained, educated about the project. They are also trained on how to use the information and technology platform, to do screening as well as to help older people in the process of using the ICT in intervention. And in the process, in the last few years, 2 years, we trained. By now, it is close to 2,000 ambassadors. And then after the training, they will volunteer in the center to help with mass screening for depression, as well as different kind of activities. We also see the ambassador training as a prevention strategy to educate older people about mental health and depression, as well as keep them busy in the process, keep them engaged in the process. As WHO said, healthy aging actually is a really good solution to geriatric mental health. Another strategy we use is to build on using a community-based participatory approach to promote mental wellness. And then so based on the 2,000 ambassadors we trained, we invite some of them to participate in a process to, a bottom-up process to, enhance the mental wellness in the community and to increase the mental health literacy for older people in the community. So it is a voluntary process, and we ask them if they are interested, they can, show hand. And then eventually we have 5 districts that we have enough people who are interested in this process. So right now we are implementing this community-based participatory strategy in 5 districts out of the 12 districts that we have JoyAge project, and about a little bit more than 100 ambassadors who have participated in the process. And then we have monthly meeting with them, and then we also encourage them to have informal meeting above and beyond the monthly meeting. So in the monthly meeting, we did a community access mapping to identify community assets that can help to promote mental wellness in the community. And then we also have discussion of a district with older people in the district on mental health issues, and then as well as the challenges. And then a lot of time we spend on brainstorming and then make decisions on how to initiate some bottom-up activities to promote, to enhance the public awareness on mental wellness. So for example, some of them may decide that they will produce some district-based poster and flyers to promote mental wellness and promote the JoyAge project. A district also decided that they will produce a promotional calendar for the year 2020. So our strategy in 2011 is to build small bottom-up projects to build success and to transfer the leadership. So in Hong Kong, older person, they are so used to, led by social worker or professionals in all type of volunteer activities. So it is not uncommon that they will have a lot of bottom-up community participatory approach project. So the first year we do is to build small projects so that they can have success, and they can also build up the communication pattern within the district. And then we also want to transfer the leadership from the HKU project staff to the community leader. And with that one in mind, by the end of 2021, each of the 5 districts should have some small project being completed and also establish their own leadership hierarchy and structure, as well as the communication pattern. We also target 2022 to 2023 to develop bottom-up community-based strategies to promote mental wellness. And this strategy need to be organized by this ambassador and implemented by this ambassador. At the university level, we will also develop a citywide advisory group for the JoyAge project from the community. So that is different from the advisory group we have for the project initiated or organized by the Hong Kong Jockey Club. So you may wonder whether this approach is really working, right? So because we are moving the project from a very structured, highly trained professionals in a community specialty clinic to elderly centers, and then also task shifting from psychiatrists, clinical psychologists, to social worker, and then to peer supporter. We also, using the community strategy to promote mental wellness. Let me show you a little bit the outcome from our phase 1 evaluation between 2016 and 2017. So these are the data from our cases who received services. So in that 3 years, the project served 4,333 people. And then we also have 52 people who are referred from the hospital authority. That means they are downloaded from the outpatient psychiatric clinic to the community-based setting. And then we also have 503 people who are the control cases. They are older people who are facing the similar mental health challenges, but they are in a district that do not have JoyAge, so they are receiving services as usual. So majority of our clients are women, and then most of them are low educated, and about 1/3 of them do not have any formal education. That is also comparable with the elderly population demographic in Hong Kong. And a majority of the clients are not married or living alone. And then most of them has mild to prodromal stage of depression, 55%. And then 19% has moderate or above depression. And then another about 20-something%, they don't have clinically significant depressive symptoms. So those are the preventive cases. So for patients or clients who are referred from the hospital authority, they have more severe level of depression. So 34% of them have moderate to moderately severe depression. So these are the outcome data. So we kind of look into the services they are receiving. And then we have 3 major outcomes, including depression, anxiety, and loneliness. So on average, they were in the services for 9 months. And then we collect data, in between from the time baseline and then discharge. And we compare them with the control group and our intervention group with the control group. So these are the kind of bivariate statistic. So if we look at the average, for example, JoyAge, the PHQ-9 depression. So before intervention, it was 6.7. And for the control group before intervention, it was 6.6. So after the intervention, it decreased to 3.1 for the JoyAge group. And for the control group, it also decreased to 4.7. So both groups show improvement. But the JoyAge group has larger decrease, and the significant level is much higher. Similarly, for anxiety as well as loneliness, we also observe very comparable results. Let me show you kind of easier understand. This is the chart to show that the JoyAge had better improvement than the control cases in all key clinical outcomes. So the first one on your left-hand side is the PHQ-9, that means the depression. And the first 2 bars are the JoyAge group from 6.7 to 3.1. And the second 2 bars are the control group from 6.5 to 4.8. So the second group is the GAD-7 for the anxiety. JoyAge decreased from 4.4 to 2.3, and the control group decreased from 4.2 to 3.4. And then the last one is the loneliness scale, the UCL-3. JoyAge group decreased from 4.1 to 2.1, and the control group from 3.5 to 3. We want to know what happened since the data I show you is just a bivariate situation. And we know that the control group and the intervention group, they are not exactly the same in terms of background and demographic, as well as baseline situation. So we did kind of a multivariate analysis. So we found out that compared with services as usual, the JCJoyAge intervention was 5.74 times more effective in preventing depression, even after we control for other covariates. So and then we look at treatment. Okay, so actually, as I said, overall we have two groups of clients. One group of clients is they have a mild to moderate level depression. So we call this one treatment group. So our target is to lower the level of depression, hopefully, to a level that is clinically insignificant. And we also have a group of people who have risk factor. So they have some score in the PHQ-9. However, their score did not reach the cutoff, the clinical cutoff. So this is what we call the prevention group. So for the prevention group, we want to avoid them to fall into depression. That means at the end, after the intervention, we want them to be able to stay at least in the in that category, or even have a little bit reduction in the PHQ-9. So the result I just showed you is the result of prevention, and this is the result of treatment. So for the treatment, what we found out actually is. We have different. So when we say treatment, we have two levels. How does it mean by improvement, right? So we have two definitions. The first definition is they are moving from depressed. So they are moving down from one category. For example, if they are moderate, then they will become mild, or if they are mild, they will become at risk. So there is one clinical jump lower, one level measured by PHQ-9. Another definition is, since, for example, if they are get a score of 11, they are moderate. But if they become 9, they will become kind of mild. So that may affect, the score. So another level we are doing is a 50% reduction of the score. So we look at both outcomes. But we found out after we control for covariate, and we found out that JoyAge group is about 3.85 times more powerful than the treatment as usual. If we use one clinical decrease in categories. If we use 50% reduction, it is about 3.55 times more powerful or more effective than the treatment as usual. We look at the peer supporter. So the JoyAge result intervention also have a significant enhance the peer supporters' understanding of late life depression, as well as they can more able to identify both symptoms of late life depression as well as identify myths versus effects in late life depression. After the training, they also have enhanced their satisfaction with their life. And then, their perception of quality of life, past, present, and future. So let me do a summary of, the JCJoyAge strategy. So the first one is the JCJoyAge. We provide comprehensive step down and then task shifting model. And our evaluation so that the model worked well. So in the phase 2, we are doing a scaling up. So what we are going is to expand the services from 4 districts in the pilot stage to 12 districts from 2020-21. And next year it will cover all the 18 districts in Hong Kong. And then the second strategy is to implement the JCJoyAge ambassador program, as well as community-based participatory approach to promote mental wellness in the community. So far, our preliminary observation and finding, it is very promising. However, we still need more rigorous evaluation. So with that one in mind, so I want to go back to the idea of, healthy aging. So what we want to advocate is there is no healthy aging without mental health. That means when we talk about healthy aging, when we talk about functional ability, we cannot ignore that mental health is one key, functional ability. They need the mental wellness in order to do what they have reason to value. And healthy aging and mental health, they are kind of reinforce each other. Also, as WHO said, healthy aging is a good solution or vehicle or means to achieve mental wellness. With this in mind, so I will start my presentation here. Thank you so much for your attention.
Thank you, Professor Lam, for the sharing. Task shifting encourages the bottom-up participation of service users and is the central theme of the latest healthy aging model. The aging population has undoubtedly called for a more innovative solution from us as a society. Let's now move on to our panel discussion. Our audience can feel free to type in their thoughts and questions about the topics. Professor Martin, Professor Lam, please.
Thank you. Hi, Mike. Can you hear me?
Yes, I can.
So actually, Mike, I have before I kind of start posting the questions from the audience. I have a question that I am interested. Since you are a psychologist by training, and if I am right, you are also very interested on motivation. So from your understanding, you talk a lot about data, what kind of data is needed, and how to do the analyze. But for most countries, having the data is the second step. The first step is to motivate people, to achieve healthy aging. So can you offer any insights as a psychologist and with strong background on motivation, what a society or a government can do to motivate older people or the community to, kind of moving toward the goal of achieving healthy aging?
This is, I think, a very central and important question. How to provide, incentives or motivation to be interested and participate in maintaining and improving a community's health. And I think the first step, it seems to me, is by ensuring what, for example, your project also does, that health is understood not as being the responsibility of an individual, because then it's that individual who's responsible and the community wouldn't have to care, but really making health an issue that's important for the community. And this is also sending a signal that the community cares about the individuals. It also creates the necessity to participate. If you want to live in a healthy community, then it is obvious that you also have to participate and contribute yourself. And this is increasing the value of your contribution. It's probably one of the reasons from the data that you presented, how people's quality of life improves when they volunteer and contribute and as peers in your program. It's not only, I think, because they contribute and do something that is meaningful for them as individuals. I think it's caused by them doing something that's important for the community overall. So I think that sense of community is the most important issue when it comes to motivation. The issue about the data is simply, as one of my colleagues points to it, if you don't measure it, it hasn't happened. And if it hasn't happened, then the difficulty is to attract or ensure that there's also funding behind it. So volunteering, or the way, for example, you set up the volunteering or the peer work, quite obviously doesn't come for free. It costs. It costs conceptual work, training of people, and so on. So I think that is another important issue that you need to prove and demonstrate how you can reach out and what effects you have, because then eventually that's the reason for continued also financial support or allocating resources. And they also are obviously part of the motivation.
So since this is a dialogue, so feel free to ask questions yourself. So from your side, if you have anything you want to know more about Hong Kong, or you have any comment on what we have done. There is a question from a participant. He said, thank you, Professor Martin, for waking up at late midnight for the audience in Asia and share with us the WHO Healthy Aging Framework. I am curious how individual data models can inform services and policies, as the latter need to be addressed the need of wider population and the balance between effectiveness and cost effectiveness. So we are so used to using those, administrative data or data from the general public, population-based data in our program planning. So how does the one you talk about individual data can be used, to understand the effectiveness and the cost effectiveness?
Well, the interesting thing is, it is what I've been talking about is a difference in the way you can use the data. So currently, what most of the studies or data represent that we have is called population-based. And what it means is that you have data on the whole population, for example, on the incidence of particular illness or the risk, if you wish. So what percentage of the population is likely to suffer from a particular illness? And without thinking twice about it, normally we take it that this risk, so as I mentioned, like a 13% risk being 65 or older, suffering from, let's say, depression, if it were a 13% risk. This is not really useful for targeting interventions. They're actually ineffective because it's the assumption that each person in the population has that 13% risk. And as I was trying to say, the individual risk is 100% or zero. So in order to make your treatment very efficient, what you would want to know is for each person in the population, how the risk of that particular person is. This would make it much more effective. Now, the question then obviously is, how can you get to such data that are very specific to a given person, but get such data for every person in the population? So these are also population-based, but they're addressing not the overall average risk, but they're addressing the individual risk. So it depends, obviously, on how expensive it is or how difficult it is to get such data. And the current developments that we see is that increasingly many data are becoming available. And the trick by now is to kind of find efficient and a good way to make use of such information so that it assists. I think they're useful also from a very practical perspective. Most assessments of, for example, the effectiveness of treating clinical diseases are also clinical tests. So they're basically standardized laboratory tests. But what you really want to know is if your intervention has an effect outside of the laboratory in the real world where these people are living. So for the first time, I think there are good ways and possible ways to testing the transfer of the intervention effects to real world environments. And that's why I don't think it's overly expensive, considering that in Switzerland, for example, Switzerland spends about 10 billion francs per year for clinical trials that don't say anything about the individual risk of a person, and they don't say anything about the effects a treatment has on the real life of those individuals. If we only used 5% of this amount, we could, I think, set up a technology and a background and the analytics to increase the effectiveness measured by real world effects massively more. So.
Totally agree. The data we have are so used to be focusing on diagnosis, once diagnosis a specific disease, but we cannot forget. Actually, in a human body, right, in an individual, we have multiple comorbidity. So we have more than one disease. So if you add all the disease up together, it doesn't add up to one person. So we have very gigantic needs, but at the same time, it may inflate, a lot of those needs. So if we take care of a person more holistically, based on individualized data, in fact, we may be able to save a lot of resources too. Instead of, kind of dividing the person into different disease clusters, and then the same person go to hospital for depression, the next day go to hospital for another one. So there is a question for me. The question is, may I know how clinical psychologists and social workers are incentivized to participate in the task shifting program, given that they are already very busy and overworked, especially during the COVID-19. That is really true, particularly for CP, clinical psychologists. In our project, the implementation team in the NGO does not have CP. As I say, there is only 600-something clinical psychologists in Hong Kong, and only 109, if my memory is correct, are working in the public sector. So it is pretty much impossible to train up or to and increase the manpower supply of either clinical psychologists or psychiatry in short term or even in long term. So as I showed, the only available professionals who has comparable training or is the social worker. So in our program, we provide more intensive training on geriatric depression for social worker. So hopefully for that 27,000 social workers, we can move a larger proportion, slightly a little bit higher percentage of social workers focusing on mental disorder and depression. Then we will significantly enhance the mental health workforce in the public sector for the community. So for the incentive, actually we provide resources for the center to hire experienced social workers. And then to fill those positions. Second one is we provide very comprehensive training. So that is also an incentive for social workers who are interested in mental wellness. And then we provide ongoing supervision by our consultants. So the clinical consultants are clinical psychologists in our team as well as experienced social worker. So they will go to visit the center, work with the social worker in case they have very challenging cases that they need ongoing support. So let me see, there is also another question. There's quite a lot of questions coming in. Another question for Mike. From WHO baseline report, we can see that after 18 years of age, more women are less able to meet some of their basic needs than men. What with the gap widening with increasing age? And I wonder what would be the underlying mechanism and what is the policy implication, if any, when there is such a gender disparity in healthy aging?
I don't have a good answer to that. I think it's in several studies we find, in fact, that with increasing age, it seems that women compared to men have more impairments. However, there's also more women surviving into that age compared to men. So it seems that there is, and we don't know exactly why or how, there are more support systems in place, or more support maybe on an informal level that makes independent living even possible. But it's also one area, I think, where we have data gaps, where we obviously do not know very well about, in particular, the informal systems or what's in place, the resources that people have in place. One of the reasons is that so far we have concentrated, as Terry was indicating, if we have data, then we have data on disease. And the disease information we have on the level of average estimates for the population. However, for example, if you want to tailor an intervention, then the tailoring ideally is that it matches the given situation. As I was trying to show, is that if you tailor an intervention on the disease, for example, dementia, assuming that people with dementia are more often disoriented, as I was trying to show, if you look across situations, then most people with dementia, most of the times, are oriented. So what you need in order to tailor to the situation would be everything else but disease information. What's important to the person? What's the context? What support's available? So you don't have to unnecessarily intervene. And the interesting news is we need, and that is that call for action for innovation by the World Health Organization, we need a competition to find out more what makes people different and how they maintain, given all the risk factors, their sense of meaning in life and quality of life. That would be much more useful, I think, also to tailor better to the given context of a person. So a long answer saying that I don't know.
Okay, Mike, before I move on, do you have any question from your side that you want to raise or you want to ask or you have comment?
As I said in my presentation, I think what you presented is really an exemplary way. I think it's really a case study that should be featured in the next status report of the World Report on Aging and Health, because it's exactly working on a community level. It's identifying the needs using the perspectives of the citizens, the participants in that area, and then using the resources that are available within that community. So I think it's, I can only say I'm very impressed by how this is being set up from the conceptual level to the very practical level.
Okay, thank you. But another one is actually, when I think about, the differences between developed economy or developed country versus low and developing, kind of country. If you look at the aging trend, 70% of older people are living in developed economies. And then most countries do not have the needed professionals, medical doctor, nurse, psychiatry, clinical psychology. But they are facing huge population aging challenge. So Hong Kong is interesting. Economically, we are more like a developed, kind of economy. But in terms of healthcare resources, if you look at the number of physicians to 100,000 people, psychiatry to 100,000 people, clinical psychologists, we are more like a middle income places. So I kind of, we have been thinking what we are doing here actually may have implication for a lower and middle income country in terms of how to move forward to prepare the country for healthy aging, as well as how to move forward to prepare the countries for the mental health challenges in aging society. So, and depending on highly trained professional is not our option. We just don't have these people here. So as much as possible, if we can task shift older people, those very complicated tasks, but break it down into smaller pieces. And we know that definitely there is a large part of it need to be carried out by highly trained professionals, like psychiatry or clinical psychologists. But there are some tasks that can be done shift to social worker, and some tasks can even done shift to peer supporter. So we believe this may be the pretty much best solution for developing economy, to really, when facing population aging, but they cannot solve the challenge of population aging by building more hospital or training more, professionals. They just don't have the resources, both money term as well as manpower.
I think that's a very general point. I think we see this with our collaborating partners, as you said, in Africa, for example, all of Africa has about 200 geriatricians. Mm-hmm. And this is a huge population. But, one issue that may have to be addressed as well is in many cases and in many countries, aging is associated with illness, and illness obviously is associated with cost. So by identifying diseases, or if you identify diseases, you have to treat them. So that is maybe one reason why you don't want to have so many specialists. Mm-hmm. The Swiss government, for example, does not allow psychologists to provide therapies independently. They have to go through a medical doctor first. Wow. And the main reason is obviously there are needs for mental health treatments, but politicians fear that more therapists means more costs. So I think one of the things that probably is important to highlight is how investing in the mental health of a population is an investment, really. It's not just a cost, it's an investment in a productive and socially functioning community. And this is highly valuable, even economically. So that's why I think WHO is also trying to emphasize this is an innovation challenge. How, for example, can we deliver just-in-time support? How can we create or use the resources that are there within a community? And as you described, they don't come for free. They basically also provide education to the volunteers. So it is really using, but also increasing the resources available in the community. And I think we need to think more in terms of showing also how what we do is an investment in a long-living society, and it's worth it. And then there might be more of a willingness to also put money into this field, because it's like for every dollar you spend, there's a return on community value and a return on even economic value in developing just-in-time decision supports that is extremely useful. I think that is also important. And so not to equal age with illness and age with cost, but equal it with investment in the community.
Exactly. We also see, for example, in our program, the ambassador is an investment in the community. So in Hong Kong, we have 18 districts, but our target is in between 2020 and 2023. We plan to train 5,000 ambassadors. That means we will have about 300-something ambassadors in each district. And they were trained, with the mental health first aid program. So they will. So that means there will be 300 active volunteers who know the mental health first aid, and they are the neighbor, and they will pay attention to what is going on, in the community, their neighbors, their family members. So, and then if they find out there are some older people who are facing mental health challenges, then before it becomes too serious, they can start the intervention. They can do behavioral activation. They can bring them to elderly center, seek help really early. So we believe this is an approach that we can kind of empower the community to be the first responder of mental health, needs, but then not depending on highly trained professionals.
Yeah.
So there is a question for me. Thank you for the presentation. May I know if dropout is serious for both the peer supporter and the ambassador program of the JoyAge? Any figure would be appreciated. Thanks. So my colleagues have been kind of helping me to collect the data while I'm talking. So actually, the dropout is really not that significant. So for the peer supporter in the pilot phase, the dropout is very minimal. At the beginning, we thought we need to continuous training in order to have a constant supply of peer supporter. But we later found out actually the peer supporter stay on the job for a long time instead of drop out. So there is some data provided by my staff. So the dropout in the first phase, the pilot phase, are very minimal between 2016 to 2019. But there was 30% dropouts when we do the transition from phase 1 to phase 2. That means they finish 3 years of services. They may want to take a break. So there was 30% dropout between phase 1 and phase 2. For the phase 2, since we are just beginning the implementation. Originally, we thought the implementation will go very smoothly in 2021, but then just when we launched the large scale kind of implementation, we were hit by the COVID-19. So but we still continue the process by offer training online or using the Zoom. So far. What we found out is 90% of the peer supporter completed the training and the practicum in phase 2, and they are hired to become the peer supporter. And so far, the dropout is really still minimal. For ambassador, also 90% of the enrolled ambassador, they completed the mental health first aid training, and then 61% of them completed the practicum. And then once they completed the practicum, they can volunteer in the project. So far we have 61% of the enrolled ambassador completed the practicum and is ongoing, engaged in the project. And the 29% that is missing, very few of them are dropped out. Many of them are still working on their practicum. So they completed the training, but they haven't finished the practicum, mainly because the implementation gets slowed down because of the COVID-19. And also my colleagues who are responsible for the PS also said, although for the people who left, the peer supporter who left the JoyAge project, many of them are still have goodwill with the project, and they also, engage in the project. So they are a good social capital for us in the community. So in those community, right now we have, hopefully by the end of this project, we have several hundreds of peer supporters of ambassadors who have mental health first aid for older person, and then know about the project. They also know about the community resources for people with mental disorder, suffering from mental health challenges. And then we should have another group, fewer maybe, 50, 60 peer supporter in the district who receive very intensive training. Some of them are still peer supporter. Some of them may quote unquote retired, from the peer supporter role, but they are still actively engaged in the project. So far we are quite happy with the outcome of the ambassador program as well as the peer supporter program. Let me see. There is also one question. There are a few more questions for Mike, but I need to find out because I think we only have less than 5 minutes. So maybe I can pick one question for Mike. So the question is, thank you very much for sharing with us 2 interesting projects. I think there is, and then could Professor Martin share with us more detail on how samples has been selected in your big data project, so as to make the project funding to be representative? I think the challenge is when you are talking about very personalized data, how does it make it representative, or does it really necessary to make it representative?
I think representativeness comes in different sizes or shapes. One is that you could say, is the persons that you examine representative of the population that you're interested in? So that is a group representativeness. Here the concern may be that because of the technology or technology acceptance or availability, there might be a selection bias. This is why we use the maximum diversity sampling procedure. That is, we try to sample purposefully, independent of the population distribution, from people with low or no education, very high ages, living lonely, not having had internet or technology before, as well as those who had it before, to demonstrate that this is feasible basically for everyone. Now the technology comes also, has advantages. Depending on the way you set up the technology, these individual data that are being collected are also owned and controlled by individuals. They don't have to be pooled, so you don't have to give them away to do good analyses. Another aspect of the representativeness is the representativeness of situations. Because if you want to treat or target an intervention to a given person, then a standard examining context is not so representative of the situations in which a person normally lives. And that's why the representativeness or the range of situations you sample from are much more important than the sample of persons that you're targeting. So going real life in addition to clinical laboratory tests is making the big difference. So the question is rather, how representative are the situations? So that is an important aspect there. I think there was another question about, often interventions are project bound, project ends, and then no continuation of the intervention. This is one of the reasons Also, WHO is calling for actions for innovation, working together with private sectors. Because in the private sector, you're interested in a sustainable business model in a way. And so they don't have a project orientation in that sense. And if you take an example, the British National Health Service, they have an innovation platform. They basically describe what's the goal of the NHS, and we could do similar things for Hong Kong or other places. And whenever you have an idea how you can do this better, more efficient, cheaper, let us know. And then there's this way of improving sustainable solutions to really don't work in isolation as a university, or don't work in isolation as a single project. But from the beginning, ideally think about the long term and work with private sector. There's so many social entrepreneurs who are interested in this. And since I've started getting into this area, I can only say that innovation competition is also a competition for finding out more about what's important to people. So that innovation also triggers a differentiated image of aging away from just the disease, simply because that's the only way you can run a sustainable business, whereas our healthcare system is organized in a different way. So I think currently working more closely with the private sector will make that sustainability more likely.
That is definitely a direction we need to pursue more in Hong Kong. So I don't think we have see the private sector as an engaging partner in this whole process. So even for the project, the JoyAge project, we do not have much strategy to engage the private sector in the project. So I think it is a very good reminder that everyone is a stakeholder in creating healthy aging, including the private for-profit sector. So Mike, I'm aware it is pretty much time up for this morning session. Once again, I want to say thank you, for you so generously, coming, being here live at a very early morning, Zurich time. And then I also know that you are also from your office, right?
Yep.
So you travel from your comfortable home to the office at the early morning, and then to be here with the participant in Hong Kong. Thank you so much. And I hope when the COVID-19 subdues a little bit and travel become more free, we can either invite you to come to Hong Kong, or I can go back to Zurich to visit you. So once again, thank you so much.
Thank you.
This is the end of the Q&A session. Thank you everyone for your ideas and questions. Also, thank you Professor Martin and Professor Lum for your thoughtful comments. We are eager to hear from your comments. Please fill in the questionnaire by scanning the QR code on the screen. This is the end of our day one event, but certainly not the end of the symposium. We would love to have you back in our keynote speeches in the coming 3 days. The topics of the keynotes are intervention for older adults with mental health needs for tomorrow, environment and mental health on Wednesday, clinical interventions and clinical training issues on Thursday. The keynotes will cover different dimensions in a healthy aging framework, which we are sure researchers, practitioners, and frontline workers in the field will benefit from the series. Also, don't forget to follow us on Twitter, JCJoyAge, to learn more about research. Chinese speakers are encouraged to like us on Facebook as well. See you again soon.